Good afternoon, good afternoon. Welcome to the Columbus Metropolitan Club. I'm Eddie Pauline, President and CEO of Ohio Life Sciences. We're the trade association for the biotech industry in the state of Ohio, and I'm also proud to serve as a member of the CMC Board of Trustees. Today's forum is part of CMC's long-running Optimal Health series. Each forum in this series is charged to explore a critical topic in modern healthcare, and today is no exception. Thank you to the sponsors of this terrific series, the Ohio State University Wexner Medical Center and Nationwide Children's Hospital. We would also like to thank the sponsors of today's forum, AstraZeneca, CareSource, and Cardinal Health. Thank you once again to our gracious host, the Ellis, for its generous support as well. We are also grateful for the Center for Human Kindness at the Columbus Foundation and the Columbus Dispatch for presenting our live stream being carried right now on CMC's social media platforms. Let's thank everyone who is supporting today's forum. So again, welcome to today's forum entitled Conquering Lung Cancer. It's the leading cause of cancer death in the United States, and it's often treatable. Lung cancer kills approximately 127,000 people annually in the U.S., but lung cancer is not a hopeless disease. In fact, it can often be treated if detected early. While treatments continue to improve with new therapies, it's early detection that could prevent vast numbers of lung cancer deaths. For Lung Cancer Awareness and National Smoking Cessation Month, we welcome two Ohio-based global leaders in lung cancer research to help us better understand America's #1 cancer killer. It's my great pleasure to introduce today's distinguished panelists. Dr. David Carbone, the Barbara Bonner Chair in Lung Cancer Research and Director of the James Thoracic Center at The Ohio State University Comprehensive Cancer Center. Dr. Jasleen Panu, Director of Interventional Pulmonary Translational Research and Assistant Professor in the Division of Pulmonary, Critical Care, and Sleep Medicine at The Ohio State University Wexner Medical Center. And our host, Sierra Johnson, anchor and reporter for NBC4 and a 2020 participant in the Association of Healthcare Journalists Cancer Reporting Fellowship. You can read all about today's panelists and their biographies by scanning the QR codes at your tables. Sierra, welcome to CMC, and we look forward to today's conversation. Thank you.
Hello, and thank you for allowing me to moderate this conversation. I've already had a chance to speak with them via Zoom, and I can tell you they are extremely knowledgeable on what is a very, very complex disease that a lot of us have, been touched by at some point in our life. So I think it'd be a good place to start by talking about your specialty, how it plays into this, and one of my favorite questions, how did you get into this field?
Maybe I will take that first. So I was trained at Johns Hopkins, and I got my medical degree there and a PhD in genetics there. And at that time, really science and medicine didn't intersect. Medicine was very empiric. We didn't have very science-based treatments, and I was looking for something to apply both my love of medicine and patient care to and my love of science. And I found that lung cancer was a perfect opportunity, a huge clinical problem, tremendous impact on patients' lives, and I felt like science could impact that care, and so I started doing that about 35 years ago and never stopped.
And I was training actually in Mayo Clinic in Rochester, Minnesota, to be an ICU doc. I was an intensivist, and in the same department, we had these 2 or 3 physicians that had specialized in interventional pulmonology, and that was my introduction to interventional pulmonology. And on the same lines, like Dr. Carbone, I realized how fast this field was growing in towards early detection of lung cancer and how vast of a problem lung cancer was. And the new technologies that were developing in IP at that front, how cutting edge they were.
Interventional pulmonary.
Yes, interventional pulmonary in that front were very exciting, and that's what drew me towards it. And then I ended up doing another fellowship at Vanderbilt in interventional pulmonology, and that's how I got introduced to the field.
And she became smart and moved to Ohio State.
Yes.
Do you all want to give an overview? I know we have some slides. It is a complex disease, but it is also one that's prevalent, and as we mentioned, it is one that is detectable. So did you kind of want to walk us through some of the slides and kind of give us a high-level look?
Just 5 slides, it's
Yes.
quick.
Just 5.
We're mindful this is not a PowerPoint, so we just wanted to give you an introduction because we are used to talking about this topic for days and days, and this is something to give us perspective where this problem lies and what we are really dealing with at this point. So this is a very common slide. You may come across it a lot on social media, but things that give us perspective here, we always think of lung cancer as something that happens to other people. That's a general perception whenever I'm talking to patients or people in the public. But it's an incredibly common disease. Over 200,000 people get affected every year. And if you were to see it in relation with a lot of other talked about cancers, breast cancer, prostate cancer, colon cancers, it's almost, the deaths it causes is almost equal to that caused by breast, colon, and prostate combined in a year, which is incredibly high. So it's a major, major problem. And it can happen to anybody with lungs. It does not really always happen in patients who smoke. 20% of people who are diagnosed with lung cancers are actually non-smokers, and that number is slowly rising. So that's our area of concern, and that's the reason why we talk about it. Next slide. If you were to look at overall lung cancer and how many patients survive what we call the word prognosis. So over a period of 5 years, if a patient is diagnosed with lung cancer, about 22%, and now the number is close to 25%, are expected to survive at the end of 5 years. But if you look at the spectrum of when they are diagnosed, if you were to diagnose somebody early in the course of their disease, stage 1, stage 2, and stage 1, you may have as high as 90% chance of survival at the end of 5 years. So that's a major difference from where we are at now. So that also presents as a massive opportunity to make a difference. And that's why we care so much about early detection of lung cancer here. Next slide. And we do have a solution for it. We have come up over the last decade with a possible test that could detect this cancer early, and that's called lung cancer screening through a low-dose CT scan. If a patient with a high risk for getting lung cancer is screened yearly with that screening CT, there's a possibility instead of finding lung cancer late, we may find it early. So this graph depicts the blue bars is the patients who got screened. They are usually found in stages 1, which is the stage where 90% of them may be alive at the end of 5 years. Whereas when they present themselves, when patients have symptoms, they are usually in much later stages of the disease, stage 3 or stage 4 actually. So the way to flip the coin to try to get this cancer early is to screen patients intentionally as much as possible early on. Next slide. And we have a recommendation for that. USPSTF now recommends that patients between 50...
Services Task Force.
U.S. Preventative Services Task Force. See, I have a sensor here, that's great. It recommends that we scan every patient who is at a high risk of lung cancer, which means who have smoked more than a pack a day for 20 years, have quit less than 15 years ago, between the ages of 50 to 80 years, with a yearly low-dose lung cancer screening CT scan, and that's a recommendation. But if you look at the graph on the side, as compared to colorectal cancer, breast cancer, and cervical cancer, this CT screening is only done in 6% of population that's eligible as compared to very high numbers in other cancers. So we have a lot of work to be done there. Next slide. We still find cancers, and this is important. We are still finding cancers, but most of the early cancers that we're finding it accidentally. We find it when patients present for other reasons. Maybe they've had a heart attack, maybe they've had a car accident, and somebody scans their chest and we find a small spot. We call it a lung nodule. And we are finding 80% of lung cancers accidentally, only 20% with the help of screening. We need to flip that. We need to intentionally look at patients who are at high risk, maybe even a broader population, to find out who can have early lung cancer and not wait for accidents to happen so that you find that out just incidentally. And early detection programs are being built to try to combine efforts so that you can build on screening, but also find these system solutions where you can find these accidental lung cancers, make sure they are followed up properly, and not miss chances to diagnose lung cancer early. So that's why we're here, and that's why we think we want to dedicate our careers towards finding a solution towards improving survival of lung cancer. So your slide is up next.
One more slide. But I wanted to start by saying how happy I am to be here and to really appreciate the Columbus Metropolitan Club for, I think, providing an incredibly important function in a community or in our community of really enabling a forum to bring people together to talk about issues affecting the region. And I'm very happy to be speaking today. So today's focus really is on early detection. How do we find these when they're 90% curable instead of when they're 20% curable or 5% curable? But I did want to mention, excuse me, I have one slide just to talk about how now there's hope in treating lung cancer as well. That the treatment for early stage lung cancer is primarily surgery, but once a cancer is not surgically resectable, we've made amazing progress in treating lung cancer. And I just have just listed here a few things. Surgery isn't what it used to be either. Used to be a foot-long scar and 10 days in the hospital. Now people come out in 1 or 2 days with 3 Band-Aids on their side due to a robotic surgery approach. Radiation therapy has been dramatically improved so that we can focus a beam of radiation and take out a lung cancer 95% likely in 1 or 2 or 3 shots of radiation. It's amazing. Sometimes we don't need to do surgery at all. And even when those techniques aren't available, we've got 2 hugely important new types of treatment. One we call targeted therapies, which is based on gene sequencing of the tumor. We now do gene sequencing on everybody's cancer, and we can often find specific genetic abnormalities in the cancer for which we have pill therapies. And I have a scan there, just as an example, that this doesn't prolong someone's life by 6 weeks or have a little bit of an effect. The slide on the left is a patient of mine whose lungs were full up with cancer. She was a never smoker, thought to have pneumonia, treated with antibiotics, and ended up having lung cancer. And she ended up on a ventilator in an intensive care unit, probably a week from dying, when we found that her tumor had one of these genetic abnormalities. And we stuffed the pills for that treatment down her tube in the intensive care unit. When I saw her 5 months later in clinic, her CT scan on the right was read officially as normal. So this is someone who was rescued from death by the knowledge, the science that found that genetic alteration in the cancer and developed the effective pills to treat it. And we see this every day, taking people in pain, close to death. We start them on a pill and they come back to normal. They spend years and years of their life with their families that they wouldn't have had otherwise. And so there's real hope there in lung cancer. And then lastly, just in the last few years, we've developed immunotherapies for cancer, which aren't a chemical. They're not a pill. They're not a poison to your body. It's a natural antibody that we give that often has virtually no side effects. And we see cancers shrink away with these treatments. And we now have many people that were on the original clinical trials of these things 7, 8, 9 years ago, who finished 2 years of treatment, arbitrarily stopped after 2 years, and are now disease-free many years later because of this immunotherapy. And I used to tell my patients with advanced lung cancer that lung cancer was treatable but incurable. And I don't say that anymore. I say that you can be cured even with advanced lung cancer. Unfortunately, it's only about 20% of the time now, but heck, that's better than zero, and we're working on the rest of it. So anyway, that's just a one-slide snapshot of the progress in treatment for lung cancer, but we really would like to focus on early detection today.
And speaking of early detection, when you had the slide about the cervical versus the breast versus the other organs that are being screened, I guess, why is there that disparity? I mean, is it because of the rules or is it because of the lack of communication? In your opinion, where do you think that discrepancy comes from?
I think there's several reasons, and you bring up a very, very important point. The screening test for lung cancer was detected, after in the 2010s, like just after that, through a trial. So it's a more earlier test than that was detected for other cancers. However, there are difficulties on different levels. There's difficulty on the systems level, on the practitioner level, and also on the patient perspective also. A large part of what we deal with is the stigma that is attached with lung cancer that keeps patients and the practitioners away from openly talking about the test. There is fear associated with what you find, and is it going to be something deadly? Do we know what we'll do with what we find? What happens if you find an accidental finding that's not actually positive? Maybe it's a false positive. Maybe you find something that is not related to lung. What will we do about it? That's on the physician aspect of things. There is a concern amongst patients, and several oncologists will agree with that. Patients feel guilty about if they have smoked for a good amount of time, they feel guilty and part responsible for finding out if they had lung cancer and what to do about it. So keeps them away from actively approaching care. And then on the other side, on the systems level, we have so many screening tests. Now we have to meet so many criteria in the hospitals as doctors work. There's a lot of overload of making checklists of which criteria to meet, which tests to meet. So in between all that, sometimes it gets pushed below because it's somewhat a newer recommendation as compared to others. So it needs time, it needs awareness that it's such a significant problem, and both amongst patients as well as physicians. And the impact that it makes is there's a lot of misconceptions about the test, like, oh, it may find a lot of false positives, means it may find findings that are actually not true. And every test has false positives, but it does not have more false positives than any other test that is done, like mammograms or pap smears. It has almost the same amount of false positives. There'll be exposure to radiation. But these are low-dose radiation scans. This is very low-level radiation as compared to what would be in a CT scan or a PET scan that is usually needed if you do find a nodule. If you find this spot early, it's not that it'll add expenses. It'll really, really cut down expenses for patients as well as physicians. And the impact that it makes, actually, the amount of scans you need to do to prevent one lung cancer is about 320. 320 scans save one life. And then as compared to, you may have to do over 1,000 mammograms, close to 700 pap smears to save one life from that test. So it really requires, it's a very useful test, and it can give you a lot more for even lesser amount of tests. So the misconception and myths are holding it down at this time, I think.
So just to add quickly to that, one reason why we're here is to help improve that number through education, but also just to describe the actual tests. So a lung cancer screening CT literally means laying on a table for 10 seconds. They turn on a machine, they turn it off, and you're done. You don't even have to take your shirt off. You don't have to do a bowel prep. You don't have to have a colonoscopy or a smashing of your body parts in the test. it's very simple, and so it is one of the easier screening tests.
Switching gears a bit, you mentioned that 20% were not from smokers, but the individuals that were smokers. Talk about how tobacco does impact the lungs, and maybe if anyone wants to, the phenomenon of vaping and how that could potentially down the road. What are we seeing? What are we thinking is going to happen to those folks?
So tobacco, besides nicotine or cigarettes, have so many multiple different chemicals, formaldehydes, other aldehydes, oils. Yep, and they contribute in so many different ways in inducing cytokine. These are inflammatory enzymes in the lungs that make them inflamed, very hyperreactive. And when this happens over time, this can lead to actually mutations or gene changes in certain cells of the lung that can lead to certain cells dividing very fast, becoming tumors. And these tumors, these cells tend to live longer, they are abnormal, and they can actually invade lung tissue as well as other organs. And that's really how tobacco or any other substances that increase risk of lung cancer act. And these substances, they not only act by themselves, but when they are taken together, they act in synergy. They increase each other's effect. So that's why we push a lot on trying to stay away from tobacco and smoking cessation. And then you touched on a point about vaping and e-cigarettes, which is another issue that we are dealing with. And actually, they called it almost like an e-cigarette or a vaping pandemic that happened in 2019, somewhere in around the state of California, and sort of spread its way throughout the United States, where about 3,000 cases of vaping-associated lung injury were reported within a matter of 6 months. And there was a perception that if you don't smoke it in a cigarette, and because you can't really see smoke if you're using an e-cigarette or vaping, it feels like it's safer. But the formaldehyde components, the other aldehydes and acrolein and sometimes oils and flavors that were being used in the cigarettes were starting this intense inflammation in the lungs and affecting patients who were less than 30 years of age in that group. And most of these patients, the 3,000, were less than 30 years of age. And a lot of them at that point ended up being in the ICU, requiring the ventilator. There is not a very clear number, like I can quote a number for cigarettes, but not a very clear number for vaping and e-cigarettes as of now of how much the risk is increased, but there's a definite correlation of these substances of increasing the risk of lung cancer, especially in the young.
Did you have thoughts to add about vaping or tobacco?
It's clearly less harmful than smoking, but the same kinds of changes you see with tobacco smoking, you see with vaping. And it's just an intrinsically bad idea to put an unknown mixture of chemicals that are sold to you by the same companies that make tobacco often, down deep into your lungs, a very sensitive organ.
Kind of on a global scale, where is the U.S. in terms of our cancer numbers, our cancer deaths? I mean, are we near the top? Are we near the bottom? Are we, you don't want to lead the pack in this type of situation, but I mean, where are we in the grand scheme of things?
Well, it's not a competition, but lung cancer is also the #1 cause of cancer death worldwide. And the U.S. incidence rates are actually going down because of the decreased smoking. Whereas in other places in the world, in less developed places, they're still going up because of tobacco companies are focusing on those parts of the world. And I do think that we have this much more advanced availability of these new drugs and the new treatments in the U.S. compared to many other countries. But there are whole counties in Ohio that don't have a single lung cancer screening CT scanner. And so we're approaching that problem now with a mobile lung cancer screening unit that we've just put into operation. We did our first mobile lung cancer screens last week with this van, in fact. And so we're really hoping to bring all of the United States up to a first world availability of these treatments.
And on that same lines, actually, United States is leading in terms of making the efforts for early lung cancer detection. And like I was recently in Singapore, the Asian countries are just trying to make recommendations so that lung cancer screening can be supported by their governments, and the same thing in Europe too. So United States is leading in those efforts. However, we have a long way to go, even though these recommendations have been in place for now close to 10 years. So a long way to go there, but we are taking steps towards that.
Switching gears to treatment, how far has the treatment of lung cancer come even in the last 10 years? Is it one of the diseases where the money is being poured in to help facilitate those different therapies?
It's really hard to overestimate or overemphasize how much lung cancer treatment has changed since I've been treating lung cancer patients. I started, as I said, 35 years ago. I would say the majority of our lung cancer patients got no treatment at all. They were just given pain medicines and their hands held and they were sent home. The average survival for a lung cancer patient back then, if they weren't run over by the dinosaurs that were roaming around the earth when I started, was only 4 to 6 months from time of diagnosis to the time of death. That was the average survival for a lung cancer patient. And now with these targeted therapies, we're seeing, as I said, we think what are cures of these advanced lung cancer patients, and we're using highly sophisticated ways to match specific treatments to patients, and every aspect of lung cancer care is dramatically improved. And pulmonary techniques have as well.
Yes, from my side, I can say, because I don't have the privilege of treating patients that way, but in terms of treatment, the diagnostic techniques we have, the biopsy techniques are getting finer and finer, so we can get smaller and smaller nodules, which help them get closer to surgery earlier rather than later. So if there's a micro chance of cancer going somewhere else, if we catch it early, patients will benefit from earlier resection. So that's how we help. And then we work hand in hand with the treatment teams like Dr. Carbone's, where we try to find out through our samples, is the cancer undergoing a change? Does the treatment need a change? Is the cancer coming back, so that it can be found as early as possible so that it can be assisted in all the ways we can?
Can you talk about the quality of life after these treatments? Is it something where you need to continue to come back to do another scans to make sure it hasn't changed and metastasized and all of that?
We follow our patients very closely. And even after patients are cured, they often want to keep coming back to see us. But the quality of life is so important in this disease because, honestly, we're curing more people, but most patients diagnosed with lung cancer, metastatic lung cancer especially, aren't cured. And so quality of life is incredibly important. And the wonderful thing about some of our new treatments is that they often have minimal or truly no side effects. And these people can go back to work, they can go back to their families, they can fly to Europe, they can do everything that you could do. They contribute to society and pay their taxes. It's not that they're losing their hair and they're vomiting every hour. These therapies really have a dual purpose, and that is prolonging life, but also maintaining quality.
No, definitely, I think, and now we have found evidence that even in early lung cancer, there's advantage of adding therapies or targeted therapies or immunotherapies in such a way that the rates of cancer coming back can be much lower. So it's looking very hopeful through all the research that has been done in the last 10 years.
And what can everyday people do to advocate for those who will be in need of treatment? Or is it something they can speak to lawmakers about? Is there legislation that we can work to enact to help kind of reduce the number of cases here in the United States? Kind of a broad, hard-hitting question, but.
Well, the first thing is to advocate for tobacco cessation. I would double tobacco tax tomorrow and use that money to, work toward improving treatments, et cetera. but also encouraging people who may have started smoking when they were in high school, and they may have quit 10 years ago or something, but still they may be eligible for screening. So if you have a family member or a friend that might be eligible for lung cancer screening, really encourage them to get it. It's painless, it's quick, it's paid for by insurance, and it really can find lung cancers early. And then, if you have the diagnosis of lung cancer, seek out an advanced comprehensive treatment center. We are fortunate in Ohio to have multiple places that do advanced care, but lung cancer care is complicated and requires genetic analyses and sophisticated equipment. So if your down the street neighbor is a general oncologist, they may do a great job, but I would encourage a second opinion at a lung cancer focused clinic. At The Ohio State, we have an entire floor of a building that does only lung cancer. We have now 12 people like me, medical oncologists, that do just lung cancer, no other cancer. We have 4 interventional pulmonologists. We have 3 thoracic surgeons, all working together in the same clinic, applying state-of-the-art care, which a general oncologist may not be able to do.
I think on a personal level, everybody can make a contribution about trying to work towards removing the stigma around lung cancer. Let's talk about it more. It's not something that happens to a certain group of people who've done something wrong in their lives. So let's remove that idea. We shouldn't be hearing people say, my mom had lung cancer, or my brother had lung cancer, he or she smoked all his life. You give a justification for having a deadly disease. That's wrong. We don't hear that for breast cancer. We don't hear that for patients suffering from cervical cancer. They don't give a reason for why they got cancer, as if they're part responsible for it. It keeps patients and families away from treatment. It gives blame. It puts a lot of, I think it's almost like a severe accusation that you deserve less life because you smoked. Nobody knew at that time. Things that we do now, we may find 30 years later, actually, that was a problem. So I think to work towards removing the stigma is a big thing, to talk about it and to offer support, just as like we talk about other cancers.
It is important to note in just a few minutes we'll begin taking questions from anyone in the audience as well as those live stream questions. So if you're here in the room, there is a mic back. Oh, it's moved. It is right there near that camera there. And if you are online, I believe you can type your questions into the chat and they will be relayed to us. If you want to, one more time, walk through the criteria for that are recommended for the lung cancer screening. I think that's extremely important.
So there are 3 main criteria, and I can simplify that. It's if anybody between the ages of 50 to 80 years of age, and those who have smoked 20 pack years, what that means is they would have smoked 1 pack year for 20 years, or they would have smoked 2 pack years for 10 years. And those who have quit in less than last 15 years, less than that, they all meet criteria for screening at this time. They will be reimbursed, or they will be covered by their insurances, most insurances at this time, as a screening test, just like other screening tests.
But there's a proposal for dropping the time since quitting, because I have many patients who quit 30 years ago that are coming in today to have with a diagnosis of lung cancer. And also, it's important to know that these criteria, that today most lung cancers happen in people who don't meet these criteria. So unfortunately, it's not currently reimbursed to screen everyone, or to screen even most of the people that could potentially get lung cancer, and especially people who've never smoked are not currently eligible for lung cancer screening. Yeah. Though that's being evaluated in some other countries, and they're actually finding other factors that can help predict risk, including things like air pollution, radon exposure. Oh, and by the way, everybody should have their radon checked in this region, because that's the number 2 environmental cause of lung cancer, and this region is particularly high for radon. Also, family history. If you have 2 people in your family that have lung cancer, you're at an elevated risk of getting it yourself. even though those are not part of the formal criteria.
Right. And like I said, so many lung cancers are presenting as spots in the lung. So if you have a spot in the lung, or if you know of somebody who has a spot in the lung, don't ignore it. Ask your doctor to see a specialist, and talk to them about, could it represent lung cancer? What's my risk of cancer? Can something be done about it? So awareness about that is incredibly important.
All right, and I think Lainey has a question from online.
You've talked a lot about tobacco and vaping, but Ohio just voted to legalize recreational marijuana, which I think you realize there's a popular perception that that's kind of a healthy thing to smoke. So how do you see this impacting future numbers of lung cancer patients?
So this is important, but because I think I mentioned that pandemic that started about vaping-associated lung injury in California in 2019, and that was around the time where the legalization had happened. And that's true, as from what we know, the risk of lung cancer from smoking marijuana appears to be lesser from what we know now, because the quantities may be lesser. But to combine it with other ingredients that are known to have high risk and proponents that could induce lung injury and lung cancer is definitely not recommended, and in no way healthy. So we use the word healthy. It may be less toxic, but not healthy in any way. And the other thing, and I'm not sure, and if it has to be used, if marijuana has to be used, maybe not use it through the lungs. Go towards other options, not the lungs.
Yeah, gummies are definitely safer, and brownies and those kinds of things. But so there is no smoke that's a good idea to inhale. And it is true that, on a per year of use, the rates may be lower with marijuana use, but that's because you don't smoke 100 joints a day typically. But I have had, maybe some people do, but I have had a patient that was diagnosed with lung cancer of a type that is almost always in smokers. And I questioned her, you've never smoked? This is very strange to get this type of lung cancer. And then I find out that she was a chronic marijuana smoker and smoked, I think, 10 joints a day or something like that. And that's probably what gave her the lung cancer. So I do think that that is clearly an unsafe behavior.
And in general, anything besides clean air, it harms the lungs. Even when you're not smoking. So say I come from India, so there are certain parts of India that you just breathe air and it's like smoking half a pack a day. So it's that bad air quality. E-cigarettes are like smoking half a pack a day, 8 cigarettes a day. So it accumulates because these toxins are going in. So any idea of whether it's any flavored smoke or any kind of smoke is an artificial agent that's going directly in the lung and interacting with molecules. And lungs is a very sensitive, thin membrane-like organ, and it's vital. Heart and lungs are vital to your survival, and it's really not recommended to do that.
Hello, I'm Jeffrey Lemichuk with CareSource. So we've talked about, we know with smoking cigarettes, if you're secondhand smoke, it's not healthy for us. I wonder with vaping and e-cigarettes, what's the risk of that secondhand smoke to us, inhaling it, the risk factors?
It's less than doing it yourself, but it's clearly a risk. And it's just contributing to the local air pollution in your environment.
How do the rates of lung cancer vary among different demographics, for example, age, gender, race, and rural versus urban? And why do they exist?
Sure. There has been more and more studies in studying racial disparities in lung cancer. And it has been found that patients coming from African American race or Hispanic, as well as lower socioeconomic status, may have a higher rate of lung cancer, and then a lower exposure towards getting care. So that's definitely of a concern. Lung cancer rates, worldwide in women are lower, because of probably the relationship with smoking, and that probably correlates with exposure to tobacco smoke and other substances that can be at a higher risk for lung cancer in socioeconomic groups as well as races also. But it has probably a lot to do with exposure to healthcare.
So actually there's a proposal to the CMC to look at disparities in cancer that maybe you'll hear about more in the future. But it's definitely true also that the rules for lung cancer screening were developed in trials that were predominantly white Europeans. And so now there's an increasing awareness to look in different populations that maybe we should have different rules for different populations. And that's being intensively studied. So we are very aware that there are disparities in different groups.
Yes, I'm Brian Hall with Primary One Health. And I was wondering, my father died of bone cancer. He smoked Lucky Strikes, died at 67, and my mother died at 52, double mastectomy breast cancer. Was there any connection with that? And also, has there been any improvement in those I see with a tube or something in their throat that they put their hand on their throat when they talk? Is there any improvement in that area?
So tobacco smoking increases your risk of multiple different types of cancer. Head and neck cancer, which is often results in the removal of your voice box and that kind of a breathing tube thing. Bladder cancer, esophageal cancer, many other types of cancer, but still lung cancer is more frequent than the others. And also there's a popular misconception. Lung cancer often starts in the lung. You can have a grape-sized tumor in your lung, but it can spread anywhere in your body, to your brain, to your bones, to your liver. And often when it's diagnosed, it's because, gee, doc, my right arm hurts. That's because you have a bone cancer in the bone of your right arm, but it started in the lung, and it's still lung cancer, even if it spreads to the bones. And so often people say they have bone cancer, or they have liver cancer, or they have brain cancer. It's actually lung cancer that spread to those sites.
No, definitely. I think it's quoted that it's about 80 different cancers that tobacco smoking or smoking can increase the risk of in different levels. The lungs are directly affected by that, but there are so many other cancers that are directly affected. In fact, when patients are undergoing treatment, their treatment responses are affected by if they are actively smoking or not. So it's, and if the cancer comes back, even that is affected. So it definitely has an incremental effect in anybody with cancer.
I think we're taking one from online, but we have a chance for one more question from someone here in the audience if you wanted to head to the mic.
Following up with what you just said about lung cancer becoming other types of cancer, are your new treatments for lung cancer affecting treatments for other types of cancer?
So lung cancer, when it spreads to the bone or to the liver, does not become a different type of cancer. It's exactly the same. It responds the same way everywhere in your body, and many of the new treatments go everywhere in your body, and every site of the cancer responds. But the types of therapy we're talking about can be applied to different cancers through molecular knowledge of those cancers. But it just fortunately turns out that in lung cancer, we have more options, I think, than any other cancer type in terms of these targeted therapies and immunotherapies. But the general principles apply for many other types of cancer.
So what would you like to leave us with as far as a call to action for our population, and especially, I'm thinking of myself as a grandparent, for the next generations coming up? Obviously, don't smoke is one, anything, but I'd like to hear what your thoughts.
My message would be a message of hope, and then there is an incredible potential. There's incredible. If the situation looks like there's a big problem, that also represents a large amount of potential. So awareness about the problem is really important, and to remove fear and stigma about the problem is extremely important, because that's how we deal with the issue, when we are actively talking about it and coming up with solutions, and pouring in efforts, resources into screening and other efforts so that we could find lung cancer early. So that would be my message.
Yeah, I'd just like to echo that if you smoke, quit. If you stop smoking, get yourself screened. If you have a suspicious symptom or spot in your lung, get it checked out. But if you have lung cancer, there's a terrific hope today of effective treatment and a good quality of life. And go after your doctor when you go see your general practitioner and ask them, do you recommend lung cancer screening to your patients? And if they don't, ask them why.
And then just one last question. Is there any technology treatments that you see coming up the pipeline that are extremely promising for the treatment of lung cancer?
Well, we are doing, at my institution, we have, I think, 60 current clinical trials that are ongoing. And some of these new treatments are what's called cellular therapies, where we can harvest the immune cells from a patient, grow them up in the laboratory, and give them back at high numbers and treat people that way. Or there's something called bispecific T-cell engagers. And I've seen, we have a brand new type of therapy in that line, where I recently had a patient that had progressed after multiple types of chemotherapy. In the past, this person would have gone to hospice for sure. We gave them this experimental agent that's one of these bispecific T-cell engagers. It's not currently FDA approved, but after one cycle, she had a complete resolution of it. All the spots in her liver, the cancer around her lungs, cancer in her brain went completely away, and it's now gone, almost, it'll be 2 years next month. She's been off therapy with no sign of the recurrent lung cancer. So I think every day scientists are working on these new treatments, and they're not just randomly chosen drugs that we scrape off rocks. These are things that we discover mechanisms in the lab, we design things to target them, and they turn out to be often highly effective, like this one, which I hope will be approved soon.
There's incredible efforts being made on the detection side, as well as treatment and surgeries of lung cancer. So there's efforts we're making using artificial intelligence to track all these accidental detections so that we can find them early, and to be able to treat them. To be able to treat a disease, you got to find it first. There's incredible efforts in trying to diagnose the lung cancer at a very small stage, where you can do a robotic bronchoscopy with CT guidance. And there was a question that people used to ask, when you biopsy, can you just not take out this cancer if it's the only spot? Why don't you just take it out? So now we are actually doing that. It's actually a possibility. It may need an incredible amount of circumstances to come together, but you can biopsy, and we've done such a case here at OSU too. You can biopsy and stage the cancer in the same procedure and also take it out if that's the only spot. So we are trying to shoot for more and more procedures like that, so it gives patients as much quality of life back.
And get enough material to do all the molecular testing that we need.
Exactly.
All right, I think that's been a great conversation. I'm going to head it back over to Eddie.
Well, great. I hope everyone found today's forum educational. You know, for me, someone who represents the life science industry, to hear so much about the life-saving research and development going on at places like Ohio State, Nationwide Children's, gives me a lot of hope for the future of health in Ohio, and a lot of economic growth as well. Big news this week, one of our member companies, Forge Biologics, which makes some of the cells that are used in the process, was purchased for $620 million by a firm outside of Ohio. So, so hopefully we keep a lot of those resources here. But exciting work. Thank you so much to our Optimal Health Series sponsors, the Ohio State University Wexner Medical Center, Nationwide Children's Hospitals, and our forum sponsor, AstraZeneca, CareSource, and Cardinal Health. And thank you to the Ellis for its support. We also want to thank our virtual seat patrons, the Center for Human Kindness at the Columbus Foundation and the Columbus Dispatch for presenting today's live stream. And our very special appreciation to today's speakers, Dr. David Carbone and Dr. Jasleen Panu, and our host, Sierra Johnson. Reminder, there is no forum next week. Please enjoy your Thanksgiving, and we'll see you back here at the Ellis on November 29th for Is Snob Zoning America's New Redlining with author Richard Kohlenberg and a great panel. Thank you again to everyone. We could not do this without you. Have a great afternoon.